Just tell me when to go. Okay, welcome everybody to this session, which we're going to be discussing home blood pressure monitoring. My name's Brian Williams from University College London, and I'll be joined in this session by close colleagues Gianfranco Parati from Milan in Italy and Rich McManus from Oxford in the UK. This session is sponsored by Omron, and the title is Home Blood Pressure Monitoring, Its Advantages and Potential Future Perspectives. I'm going to make some opening remarks, and then we'll hear two talks, and then we'll have time at the end for discussion. So my opening discussion is really the current positioning of home blood pressure monitoring in guidelines. These are my disclosures. When we produced the guideline in Europe in 2018, for the first time, we highlighted that out-of-office blood pressure monitoring, either through HBPM or home measurement, could be used to confirm the diagnosis of hypertension. We also highlighted that out-of-office blood pressure measurement, either HBPM or home, should be considered in people with high normal blood pressure as a means of trying to identify masked hypertension. In the United States, their guideline a year earlier also included out-of-office blood pressure measurement for the first time. They gave a level 1 recommendation for accurate measurement of blood pressure, which is obvious, and then they went on to say, with a level 1A recommendation, that out-of-office blood pressure measurement is recommended to confirm the diagnosis of hypertension, just like in Europe, and for the titration of blood pressure lowering medication in conjunction with telehealth counseling or clinic interventions. So really quite a dramatic change in the US too, although here predominantly based on home blood pressure readings rather than ambulatory blood pressure measurement. We've heard earlier in this meeting about the importance of identifying white coat and masked hypertension. And we know that both of these are common and cannot be diagnosed easily with clinic blood pressure measurement. And we know that white coat hypertension is more common in grade 1 hypertension in the office, and is unlikely to be normal, the blood pressure on out-of-office readings, when blood pressure is grade 2 or more. And we know masked hypertension is much more common in people with a blood pressure in the high normal range, and is uncommon or unlikely to be abnormal if the office blood pressure is less than 130/80. So they're areas where you could target home blood pressure monitoring if you wanted to detect white coat or masked hypertension, but probably the easiest way to do it is simply to do it to confirm diagnosis and try and detect white coat hypertension, and also think about monitoring people with a high normal blood pressure. If I go back here, this is what we said in Europe about home blood pressure monitoring in 2018. The advantages is that it can identify white coat and masked hypertension. It's cheap and widely available. It measures blood pressure in the home setting, which is usually more relaxed than the doctor's office. It engages the patient in measurement, which may improve their adherence to therapy. And it's easily repeated over long periods of time, which may give you a better impression of the overall blood pressure trends. It's interesting that the 3 disadvantages that we cited were the fact that only static, i.e. seated blood pressure measurements are generally available. It wasn't truly ambulant. There were no nocturnal readings available, although we had noted that devices were being developed that could measure nocturnal blood pressure at home. And there's also the potential for measurement error, but of course, there's a lot of measurement error in clinic blood pressure measurement too. George Sturgeon and colleagues on behalf of the ESH updated the sort of recommendations on home blood pressure measurement recently in an article in the Journal of Hypertension, really summarizing predominantly the same things, but with a bit more emphasis on some of the limitations, particularly around avoiding patients becoming too anxious and over measuring blood pressure, and trying to do it in a more balanced and realistic way, but really emphasizing the advantages that I've just discussed. Now, let me turn to this concept of potential disadvantage of static home readings. I'm not so sure they are. Seated readings do provide consistency through a stable and uniform method of measurement. And in many ways, these measurements are most likely to represent the underlying blood pressure load upon which we see short-term variation in blood pressure superimposed. In many ways, it's a bit like nighttime blood pressure on ambulatory monitoring, which is also a much more standardized measurement with repeated measurements while somebody's asleep at night is giving you an estimation of the underlying blood pressure load without the overlying variation. There's also the advantage that the self-measurement by a motivated patient is more likely to be performed accurately than a measurement in routine clinic. So the reading may be fundamentally more accurate, and it replicates the office blood pressure measurement used in clinical trials. So although people often dismiss this simplicity of twice daily home seated readings, in reality, it might provide us with a quite accurate estimate of underlying blood pressure values and also replicate what's going on in the trials. And it also, of course, allows reading over multiple days to look at consistency and variation in blood pressure, which might be important. In terms of what the guidelines say about how to measure blood pressure at home, again, remarkable consistency now across the world. In Europe, we said in 2018, home blood pressure was the average of all readings performed with a validated monitor for at least 3 days, and preferably 6 to 7 days. After 5 minutes rest seated with 2 measurements taken at each measurement session, morning and evening, with 1 to 2 minutes apart between readings. And in the paper I just referred to that's recently been published by the European Society of Hypertension, quite similar recommendations, measurements of 7 days, but at least an average of 3, morning and evening measurements, adding before drug intake if treated and before meals, and again, 2 measurements on each occasion, 1 minute between them, with quite a helpful diagram emphasizing the factors that can influence blood pressure measurement. Now, in terms of definition of hypertension, this has always been a bit of a challenge because we've used clinic blood pressure readings to define hypertension for almost all clinical trials. And various studies have been done to look at the correspondence between equivalent threshold values. So what we said in Europe was the diagnostic threshold for hypertension on home average is 135/85 or more. And that's equivalent to an office blood pressure of 140/90 based on an average of 3 to 6 days of home readings. And compared with office blood pressure, we said the home blood pressure was most likely to provide more reproducible data and also more likely to be closely related to hypertension-mediated organ damage, particularly LVH. So that was quite straightforward in Europe. In the United States, of course, they had 2 different grades of hypertension. Grade 1 was a clinic blood pressure of 130/80, which they suggested would be equivalent to a home blood pressure of 130/80 on average. And that may seem a bit surprising, but we know that as you lower that threshold, then the 2 values tend to come together. And for 140/90, which is grade 2 hypertension in the United States, they suggested 135 as a home average, which is identical to the European recommendations. In terms of treatment targets, well, of course, we've all lowered the targets in recent guidelines. And the office, if you have an office target of less than 130/80, as is routine in the United States and recommended for younger people in the European guideline, then this is suggested to be equivalent to a home average of less than 130/80. I think the other thing that's interesting is the legacy of COVID, because one of the positive aspects of COVID, if there is such a thing, has been the fact that by necessity, many patients have had to get much of their healthcare at home, remote from a clinical environment, and therefore this has encouraged more home blood pressure monitoring. And patients have begun to realize how relatively straightforward this is and how helpful the information can be. And one hopes that when we come out of this pandemic, this positive legacy in terms of blood pressure measurement will remain. Final point is guidelines often stated that the correspondence between home average and outcomes seem to sit somewhere between office blood pressure and ambulatory blood pressure, which had the strongest predictive value for outcomes. This is an updated paper from led by Kazukario in Japan, looking at community-based measurements of home blood pressure and their link to outcomes, and also clinic-based measurements of home blood pressure and corresponding values in relation to home readings, and again linked to outcomes. And the conclusions are that these outcomes are strongly related to home blood pressure average. So there's good correspondence between these values and outcome. So in summary, home blood pressure monitoring is guideline recommended for the first time in the last series of guidelines. It improves diagnostic precision and helps identify white coat and masked hypertension. It better engages patients in the measurement process. It probably provides better prediction of hypertension-mediated organ damage versus office blood pressure, at least the way blood pressure is usually measured in the office. And there's increasing evidence of better prediction of outcomes versus office, although probably not as strong as HBPM. Let me just finish on these two disadvantages, because guidelines suggested that two of the disadvantages were a lack of mobile readings and also a lack of nighttime readings. Many of you will have seen this paper, again from Dr. Cario in Japan, looking at a device which has been developed by Omron, which can be worn on the wrist during the night, and it will measure blood pressure at 3 predetermined times during the night after pushing the nighttime mode button. So this will give some measurements of nighttime blood pressure. And then this device, which is incorporated into a watch strap, it does include a cuff. We've done some studies with this, and I was doing some studies with this, which is quite interesting. And this shows quite good correspondence with ambulatory blood pressure, although the readings are self-activated with this watch rather than automated. So again, this concept that home readings could also be gathered by wearables other than standard HBPM is beginning to emerge. So after 125 years of conventional blood pressure measurement, the last decade has seen quite a big expansion in home blood pressure monitoring and devices, and it's now endorsed in all major guidelines across the world. Compared to office BP, home readings seem to provide better evaluation of blood pressure levels and control, better identifies blood pressure phenotypes, and better predicts outcome. And home blood pressure also engages patients, as I've said, which may help improve adherence and blood pressure control. And advances in technology continue to create more sophisticated devices, expanding the spectrum of measurement beyond home-seated blood pressure to include daytime and nocturnal measurements on multiple days. But we still need to better understand what the benefits of these additional measurements are. And for the moment, there's very good benefit in terms of the conventional seated home readings that are widely recommended in modern guidelines. So with that, I will stop sharing my screen, and I'd like now to introduce Gianfranco Parati, who's going to give us a presentation on nocturnal blood pressure measured by home devices, the evidence and the perspectives for clinical application. Over to you, Gianfranco.
The beauty of the hybrid meetings, we are a bunch of people here in Italy just watching you from UK and try to put things together. Well, my topic is to discuss nocturnal blood pressure by home devices. And I would like to start with a naive question. Why should we measure blood pressure during sleep? Well, there are very important good reasons there. First of all, we spend 1/3 of our life sleeping, which is something, and this is underlying the importance of measuring blood pressure also in this condition. Then we know that sleep is characterized by quite a complex involvement of many control mechanisms, and might be a nice model to investigate neural cardiovascular modulation, as done in many studies. And also, we need to understand why some cardiovascular events are characterized by a different circadian distribution some of them occurring at night more frequently. So what happens at night is also clinically important. And we know that nocturnal blood pressure is the best predictor of outcome in hypertension based on a number of studies. However, the behavior of blood pressure at night is quite complex. Here you find a sleep study, and in the lower line you see a beat-by-beat blood pressure recording. You see the different sleep stages from wakefulness to stage 1, 2, 3, and 4, and then REM sleep. And as you know very well, when you go from stage 1 to stage 4, there is a progressive reduction in sympathetic activity and also a reduction in blood pressure. While when you enter REM sleep, you find something different. You find the line thicker here, which means higher heart rate and also higher blood pressure level. So the night is also complex, and we need to pick up what happens hemodynamically in this condition as well. Of course, this is a very careful beat-by-beat recording we may use in research or during polysomnographies, but in real life we are using something simpler, such as HBPM. And as you know very well, we have started identifying the behavior of blood pressure at night in our patients by defining them dippers or non-dippers, depending on the behavior of blood pressure at night. If you consider the recent European guidelines, there is an acknowledgement that sleep is important to investigate, and the acknowledged approach to definition of dippers is a blood pressure reduction less than 10%. We know that blood pressure dipping is a normal distribution, but some cutoff, although arbitrary, might be useful for defining a given condition. We also acknowledge a number of mechanisms behind the nocturnal blood pressure dipping, including sleep, and in case there is a reduction in nocturnal blood pressure fall, sleep disturbance, which might be also accompanied by obstructive sleep apnea, obesity, high salt intake, orthostatic hypotension with some reactivity at night due to autonomic dysfunction, CKD, diabetes, and old age itself. But what is a general observation made by several papers that this behavior of blood pressure at night is not really very reproducible. It may be reproducible in the sick patients where there is an important derangement, but in the average hypertensive population might be quite variable. I said that this is very important. If you consider the classic studies, that's a Sistio study with the placebo arm, we found that, of course, the prediction of event was there when you consider the office pressure, but the prediction was much better for daytime, 24-hour, and nighttime blood pressure. It was an intervention study in elderly with isolated systolic hypertension, but the same behavior was found in the Dublin study in a population of hypertensive people and in the Pamela study in a general population. Nighttime pressure seems indeed to be a sensitive predictor outcome. We need to quantify this parameter as accurately as we can. Also, the dipping, the change is important. Again, this is the Sistio study, and in this quite complex slide, if you look at the details, you find that whenever you account for the behavior of 24-hour average systolic pressure, whenever there is an increase in night-to-day ratio, which means less dipping, you find an increase in the risk of events, in this case of stroke. The Japanese study several times were highlighting the importance of dipping. This is the Hoazama study, and in this population, with an outcome-based series of observation, they were demonstrating that if you are non-dipper, or even worse, inverse dipper or risers, when blood pressure is rising at night, you might have a higher mortality, cardiovascular mortality and non-cardiovascular mortality, and also higher rate of stroke, as shown in other papers. But the behavior of blood pressure at night can be even more complex. This nice paper by Kazu Kario is just schematizing all what might happen, so might have the different behaviors related to the degree of blood pressure reduction, going from extreme dipping to dipping, non-dipping, and rising. But you might also have phasic events during the night due to arousal or REM sleep or sleep apnea that might create additional changes in blood pressure. And then, of course, you have to compare what happens at night with what happens in the early morning, where you enter in the REM sleep stage, which is more frequent in the last hour of sleep, and might have this morning surge, which can be preceding the actual time of awakening. And in sleep apnea, this is a problem that we have to investigate carefully. When you have an upper airways obstruction and you start stopping breathing for a few seconds repeatedly during the night, this is responsible for hypoxemia, and through a stimulation of the chemoreflex, you get a sympathetic activation and a blood pressure rise. In our sleep studies, we are combining very often oxygen saturation, mechanical aspects of ventilation with beat-by-beat blood pressure, and you find this typical pattern. Whenever there is a hypoxemia due to apnea, when you start breathing again, you get a blood pressure peak. And this kind of behavior is not a healthy behavior of blood pressure, might be really responsible for problems. Indeed, that's a typical background for the finding of a blood pressure rising pattern at night, which is characteristic of people with obstructive sleep apnea and obesity in many, many instances. And the behavior of blood pressure due to apneas, for example, can be quantified by blood pressure variability. This nice paper by Professor Palatini was indeed focusing on nighttime blood pressure variability, both for systolic and diastolic, and was clearly showing that the subjects having a higher nocturnal blood pressure variability were characterized by much higher events rate. So again, also the dynamics of blood pressure at night are really quite important to investigate. The problem is how to do this. We are recommending usually ambulatory blood pressure monitoring. These are our position paper in 2014, and a number of indications are there for HBPM, but there is a special focus on nocturnal hypertension and the assessment of dipping to identify also the pattern characterized by isolated nocturnal hypertension, which can be a kind of masked hypertension in many patients. However, although HBPM is the gold standard for nocturnal blood pressure measurement so far, is not easily accepted by all patients because it might disturb sleep due to the repeated measurement at the arm level. Many patients do not like to do it or to repeat it in case you recommend performing repeated assessment because they don't find their sleep comfortable enough. They can be woken up, and this might even disturb the partner in bed sometimes. The general practice is not easily available. Many GPs don't have facilities to have HBPM performed in any case, and not certainly in their office, and if not in very rare cases where they're working in associations. And the repeated measurement, we are asking for at least a measurement every 20 minutes a day or 30 minutes a night. Sometimes this might really interfere with sleep. And in any case, even in the best case of best performance, you have one night, which might not give you a precise definition of the typical nocturnal behavior because you don't have repeated assessment and the reproducibility might not be so good. This is an interesting observation done with a complete polysomnography of what is the effects of arousal. Here you find a cuff inflation here. When the cuff pressure is increasing, then you find arousal in the EEG, which is followed by an increase in systolic blood pressure and diastolic blood pressure. And the difference can be as high as 30 millimeters of mercury in some cases, and which may be found quite frequently in people performing polysomnography accompanied by a blood pressure monitoring, continuous monitoring, and this might really create quite a problem in the assessment of the prevalence of hypertension, the effective behavior of blood pressure at night. Now we have new possibility, you, as Brian were already announcing, we have a possibility to use home blood pressure devices modified thanks to the modern technology to allow for automated nocturnal blood pressure measurements. In the very recent paper we just published a few weeks ago is an update of our original position paper, Home Blood Pressure Monitoring. We were already acknowledging this. We compared the previous position paper in year 2008 with the current one. We really found quite a difference in this setting. Let's say 10 years ago, there was no evidence of any possibility to use home blood pressure for nocturnal measurement. Now we have the technology for doing this, and this is opening a new perspective. Indeed, based on the available studies, this device has been already investigated in a few studies in Japan mostly. We have the definition of the technology, which may allow for some automated home readings at night, which may provide data partly similar to what you may obtain with ambulatory blood pressure monitoring. And based on the very preliminary evidence, we'll see a few examples later, at least you might use this home device for 2 nights, performing at least 3 automated measurements per night to have information which might approach the information you may get from the classic nocturnal blood pressure measurement with HBPM. And in such a perspective, nocturnal home blood pressure monitoring might be an alternative for investigating nocturnal hypertension, non-dipping, and possibly also the consequences of sleep apnea in some patients. Obviously, if you are using a home device, again, with the arm cuff inflation, you might fall into the same problems as with the HBPM. So the proposal now is to try to use the wrist cuff. As you know, the wrist blood pressure measurements are not recommended routinely for home blood pressure for a number of technical issues, but in the night there might be probably a spatial perspective which might imply an exception, and we have to test whether use of wrist devices might indeed perform better as compared to the arm cuff inflation. This was a paper we published a few years ago, just investigating the previous available studies on some preliminary experience with the home blood pressure measurement at night. And in this particular perspective, we're highlighting all the factors possibly affecting nocturnal home blood pressure. Lifestyle, so meals, exercise, sleep time, and quality of sleep, just to give you a few examples, or smoking in the evening, for example. Environmental factors, the room temperature, the room lighting or sounds, movement in the room, children or the spouse moving in the same room might be also affecting the blood pressure. And also the device measurement and the condition can be important. The type of device, upper arm or wrist, for example, the cuff size and position, the number of measurements, and the cuff noise, the cuff inflation noise might also be a factor. And finally, of course, we have a number of clinical factors that you know very well, including autonomic dysfunction, poor quality of sleep, cardiac or renal problems, so far and so forth. The very first initial studies were trying to test some of the possible differences between upper arm and wrist blood pressure measurement. In this study by Professor Imai and co-workers, they were performing nocturnal measurement with a home device at the 2 levels, and they were investigating the sleep quality. And they found that there was quite a difference. Those using the home or the night when the home blood pressure measurement at the arm level was performed was characterized by a poor sleep quality, while the night when the wrist cuff was used were characterized by a much better quality of sleep, which might be suggestive of possible improvement in the sleep quality. There are also some preliminary data on the possibility to correlate with the organ damage. There's a nice Japanese study correlating the blood pressure measurement at night with HBPM or with the home device with left ventricular mass index. And you find a significant correlation in both cases, slightly better, if you want, with the home device than with the HBPM. And this is the last born in the family. That's the new wrist cuff device produced by Hombron for nocturnal blood pressure measurement. It can be used also for the daytime, obviously, and as a special software for measurement in the seated or in the supine position, because the 2 different positions imply the need of a different algorithm. It may provide during the night 3 automated measurements that can be set at 2 a.m., 4 a.m., and 4 hours after going to bed. It's very silent because there is a modified engine to inflate the cuff. Has a Bluetooth connection with a special app which is connecting and collecting all the data, can be used for communication with the doctor. May have a 300 measurement memory, and there are 2 different cuff size for two different wrist circumferences. There is also a special cuff structure, the so-called sigma cuff, which is improving the occlusion at the wrist level, which is a difficult site because of the tendons and the bones and the presence of two arteries in this particular setting. And of course, there is a special algorithm for the nocturnal measurement. This is how the cuff looks like on the right-hand side, which may provide a better occlusion at the wrist level as compared to the classic cuff. And this device was validated by the group of Professor Cario according to the recent ANSI-AMI ISO protocol. This was done in 90 patients roughly, and the validation was done in the two positions, in the seated position during the day, and then in the supine position, having the palm in different position itself, on the side with the palm upwards or downwards. And you find here the data of the Balan-Allman plot. You find that the difference between the classic arm and the wrist device measured in this position were not larger than 1.2, 1.4, or 2.2 millimeter of mercury for systolic, just fitting the requirement for validation. The slightly worse performance was with the wrist on the side, leaning on the bed, while the upward or downward position were better. And the same behavior was found for diastolic blood pressure. So based on this study, there was evidence of a validation according to requirements, and the performance was also quite good in the seated position, which was not during sleep, obviously, but was again testing the possibility of using the two different algorithms for the two positions in the same subject. Of course, there was an improvement in the pump inflation noise, and the technology was improved as compared to previous devices were tested in the previous years. Another study by the group of Professor Cario was again comparing the arm and the wrist position in the office, so during the day, and during the night. In the office, the comparison was in the seated and the supine position, comparing wrist and upper arm measurement in a sequential manner according to the requirements, while in the night there was one measurement every hour, and then there was a comparison between the wrist and the upper arm cuff devices because the two cuffs were inflated at 3-minute differences. And these are the data. There was a very similar level of systolic blood pressure measured at the wrist or the upper arm in the different condition of the study, while there was a slight underestimation of diastolic blood pressure at the wrist level. The authors are interpreting this in terms of algorithm, but it might just be physiologic. We know that if you go to the periphery, the pulse is amplified, and diastolic pressure tends to be lower than at the arm level. So that might be just a physiologic finding. And when they were also comparing measurement done automatically every hour, again, you don't find any significant difference between the upper arm and the wrist position for systolic blood pressure, while there was, again, a slight underestimation at the wrist level of diastolic blood pressure, probably for the same reason I was mentioning before. They also were using a questionnaire on sleep quality, and they were asking people if there were awakenings during the night. Well, there was a slightly higher number of awakenings the first night. This was done over 2 nights, as compared to the second, which implies the possibility of some training. And when they were asking specifically what was the awakening rate when using the wrist device or the arm device, as you see with the upper arm device, the number of awakenings were greater than when using the wrist device, which is again reinforcing the concept that this approach might produce a much less important disturbance of sleep. Then they tried also to compare the different schedules. They were comparing 2 possibilities, either having 3 measurements shortly after going to bed, in the hours following going to bed, or just using the automated setting, the clock approach, at 2 a.m., 4 a.m., and then 4 hours after going to bed. And of course, they found a slightly lower pressure when the blood pressure was measured closer to the time when you go to bed, because we all know that the sleep is much deeper in the first part of the night, which might explain this particular difference. And when they were comparing the average of the hourly measurements, obviously the clock approach was closer to the average of the entire night than the approach based on the early measurement, because of course these were picking up the values in the time when the sleep was deeper. Concerning reproducibility, again, the group of Professor Cario were comparing measurements at different nights, 2 nights, and the reproducibility was very good for the average blood pressure values. They also measured nocturnal blood pressure variability with the standard deviation and the average real variability index. And this was less good with only a couple of nights. So their message in the end was that, okay, the measurement is reproducible as far as you focus on the average values over 2 nights. While if you want to measure blood pressure variability, you need probably more measurements or more nights. In conclusion, what is still needed after this very early experience? Well, first of all, we need more studies comparing this new home device with the ambulatory blood pressure monitoring to better test the reproducibility and reliability, also to test the preference by patient in a larger group and the cost effectiveness. The improvement in the technical aspect is there, but might be refined eventually. So the cuff performance needs to be relatively good, but it might be investigated more. The algorithm for the supine position, which has to take into account the different level between wrist and the heart, has to be checked again. And the pump noise is already much better, but could be even improved. Then, of course, we have to define what is the best schedule. I mean, how many measurements per night? Now the device is set for 3 measurements, which is a compromise between less disturbance and enough information. But is this the best approach? And on how many nights? One of the advantages compared to HBPM, here you might have this done almost every night for a week if you wish, which may be really giving you very reproducible information. But what is the minimum number of nights to obtain significant data that might not be too much disturbing? And finally, of course, there are other factors related to what is affecting the nocturnal pressure at night, the association with organ damage and events, obviously the prognostic impact, the real diagnostic usefulness of this approach, and then, of course, the definition of the targets for treatment. So in conclusion, based on what we have available, certainly the progress in technology has now given us new possibilities. And these new home BP devices may allow a reliable blood pressure measurement at night based on the early studies. Definitely, the evidence we have from the Japanese studies is telling us that this approach is feasible, is accepted by patients, and provides information on nocturnal blood pressure, which is quite similar to what you can derive from HBPM, including the definition of non-dipping. Definitely, we need more studies because we have to see whether this approach is really an alternative to the HBPM for a reliable assessment of nocturnal blood pressure, and this might be also tested with the perspective of the cost efficacy and also the diagnostic precision. More research is than needed, but certainly the evidence we already have is very encouraging and may provide us a much easier tool for investigating blood pressure at night. Thank you for your attention.
Thank you, Gianfranco. It was a really superb review, and it is fascinating how the technology is being evolved to try and improve the measurement of nocturnal blood pressure. Maybe we can get back to that in the discussion, but before that, we're now going to hear from Richard McManus, who's done a huge number of studies and very important studies in the concept of telemonitoring and self-management of hypertension, and he's going to give us a review of that subject now. Over to you, Richard.
Thank you very much, Brian. So these are my disclosures. And over the next 20 minutes or so, I'm going to introduce the issue and consider the problem. Think about the attributes needed for self-monitoring, and then go through some data both on telemonitoring compared with self-monitoring on its own, thinking about self-management where patients get involved, and then finally, more recently, thinking about digital interventions before hopefully bringing it all together. So the problem is, as I know that everyone is aware of, is that in patients with raised blood pressure are often unaware of that fact. And even when they are aware, they are often not controlled despite taking medication. And this seems to be both through patient factors and professional factors. And some of this Brian talked about in his talk. We know that adherence can be an issue, perhaps due to side effects from antihypertensive medication, but also potentially because patients may be started on medication at risks that they don't feel are sufficient for their need to take it. We also know that lifestyle factors are often difficult, and obesity is very prevalent. In terms of professional factors, workload, particularly over the last 18 months or so with the pandemic, has been extreme. And there is significant evidence of lack of professional action in the light of this. And we know from research that where the patients are perhaps seen 4 times a year in primary care, but less than half of them will receive intensification where the antihypertensive medication is found to be raised. This isn't just a primary care problem, it's a problem for everyone. In the current context, as Brian also discussed, the way that we look after patients has changed very significantly. And many face-to-face appointments are not happening. You can see on this is from a group in the southwest of England, where you can see that prior to the pandemic, about 2/3 of all the contacts were happening face-to-face, but this is last March, going down to around 10 or 15%. And that has pretty much settled down and is still the case in large numbers of primary care settings, and I suspect for many of you in specialist settings as well. And this is important because without some means of successfully monitoring patients' blood pressure at home, it can lead to delays. And we know that such delays of relatively modest amounts of 6 weeks or more in lack of intensification of antihypertensive medication can lead to increased cardiovascular events, which is worse as the blood pressure is higher, which is, I guess, what you'd expect. So self-monitoring, as we've heard, is a useful tool. We are, I think, all arguing this afternoon, but perhaps in this talk particularly. We know that we have a lot of patients who are self-monitoring. In the UK, it's about 40%. And even of people without hypertension, perhaps 1 in 5 have measured their own blood pressure. In other settings, this can be higher, particularly in some specialist settings. We know that the STEP study recently published in China was looking at self-monitoring, and self-monitoring is becoming more and more important there too. We now have, although monitors are often available that are not validated, there are actually very many hundreds of monitors now that have been validated. And there's no reason why patients shouldn't be using those. And those monitors can be integrated with the electronic patient record. This is an example using the Apple Health Toolkit, which is done in the UK. Clinicians often worry about whether patients' own monitors are accurate. And this has been looked at in a range of practices. In the West Midlands in the UK, over 300 patients' monitors were checked in exactly the same way that one checks monitors in a clinic. About 3/4 of these passed all tests, which doesn't sound particularly good. However, when one drilled down into the data, the monitors that fail are largely due to being rather old, more than 5 years or more old. And particularly those that were unvalidated in the first place, perhaps unsurprisingly, those with large cuffs. Whereas 95% of validated monitors that were 4 years or younger were accurate. In terms of clinicians, in the UK, we know that the vast majority of primary care physicians are using self-monitoring now, and that since decade or so since NICE guidance first recommended out-of-office monitoring for the diagnosis of hypertension, the levels of that have increased. The diagram at the bottom shows some work done looking at what happened in relation to those guidance. And you can see that on the left-hand side of the graph, self-monitoring is at a relatively low rate with a big jump immediately after the implementation of that guidance. So what about benefit? Yesterday in some of the talks, there was significant skepticism about the benefit of treating antihypertensive or titrating antihypertensive medication on the use of self-monitoring. But I think that hopefully we can see that that has changed. Prior to relatively recently, the original evidence on titrating using self-monitoring suggested that perhaps blood pressure was no better or even slightly worse using self-monitoring. So we set out to see if that was still the case in the Tasman-4 trial. And this randomized people with a diagnosis of hypertension whose blood pressure at baseline was above 140/90 despite treatment, provided they were not taking more than 3 antihypertensives and that they didn't have AF, which was largely to do with the fact that home monitoring doesn't really work very well in AF. They were randomized to either standard care with titration through clinic monitoring, to self-monitoring using a manual method, or to telemonitoring. And we were powered to show differences, relatively small differences in systolic blood pressure, 5 millimeters of mercury. Manual blood pressure was recorded in a pretty standard way, just using a chart that's similar to many that could be used in your clinics and posted to their GP. The telemonitoring system was also very simple, and that was text-based. This had the advantage of reminding patients to monitor, and they were asked to monitor for the first week of every month. It reminded them if they didn't monitor or if they hadn't done enough readings, and they were asked to do the equivalent of 12 readings over 3 days, which, as Brian has mentioned, is guideline recommendations. And it alerted them if the blood pressure was very high or very low for immediate action, and if the average over a week of readings was raised, it asked them to contact their GP, and GPs got their own reminders. Our primary outcomes showed that self-monitoring and self-monitoring with telemonitoring were both significantly better than blood pressure managed through clinic readings. And this was at a year. After 6 months, the telemonitoring group was also better. However, it wasn't significant for the manual self-monitoring group, suggesting perhaps that blood pressure was lowered slightly quicker in the telemonitoring group. We had good levels of follow-up with only 15% dropout after a year. The mechanism for this appears to be enhanced use of antihypertensive medication, which was seen both in the telemonitoring group and the self-monitoring group. And importantly, there was absolutely no difference in adverse events. We modeled the effect of cost effectiveness and showed that using the £20,000, which is slightly more than that in terms of euros per QALY threshold, which is standard in the UK, that both self-monitoring and telemonitoring were cost effective. And actually there was little to choose between the two in terms of the likelihood of cost effectiveness. So this shows benefit, at least in terms of lowering blood pressure. We can maybe discuss the issue that there are no outcome trials of self-monitoring for titration of antihypertensive medication, but it shows lowering of blood pressure using this method. But what about giving patients more control, getting patients to do their own titration? Well, we've looked at this in 2 trials, which Brian was also involved in the Tasman 2 and Tasman SR trials. And we looked at this concept of self-management, which is self-monitoring with self-titration following a pre-specified schedule. And I will go and talk a bit about what that means shortly. And some of the trials used telemonitoring, others didn't. Setting out the pre-specified schedule requires GPs and patients to meet at the beginning to decide on potential medication changes to make over the coming months. And medications can be added or increased with additional instructions, for example, if blood monitoring is needed. And the kind of process that needs to be done here is of setting goals. Patients get a review about what medication they're taking and any intolerances. A plan is made prospectively to decide what changes a patient can make. And the idea of this is to try and reduce that clinical inertia, because if you've already decided what to do, then with evidence of a raised blood pressure, it becomes easier to make that change, and in this case, to allow the patient to make the change. Consideration of monitoring, as I've mentioned, and reassurance that this is a reasonable thing to do. The interventions all used a traffic light system with red and blue for either very high or very low readings, green for normal readings, and amber for readings that are consistently above target, such that an increase in medication is needed. The home readings were adjusted for the fact that blood pressure is lower at home, typically 5/5, as you've seen at the 140/90 level. And where there were high-risk groups involved, we used lower targets. And in both of the trials, we found significantly lower systolic blood pressure at a year. In the essential hypertensive group, this was just over 5 millimeters of mercury. And in the high-risk group, which was people who had diabetes or coronary heart disease or a previous stroke or chronic kidney disease, we found nearly 10 millimeters systolic reduction of blood pressure. Again, we think that this is probably due to medication changes, with about half an antihypertensive in addition used in the hypertensive group, perhaps slightly less in the high risk group, but there was evidence of an increase in dose there. Side effects, again, were very, very similar. Absolutely no difference, perhaps surprisingly, in the high risk group. Some evidence of increased ankle swelling in the hypertensive group, perhaps due to increased use of calcium channel blockers. We looked again at modelled cost effectiveness in both trials and found really very good cost effectiveness in the hypertension group, between 2,000 and 6,000 euros per QALY. In the high risk group, it was actually dominant, which means that that treatment using self-monitoring, self-titration was both more effective and cheaper. These were used using relatively old methods of telemonitoring. So we set out to see, could this work in a digital intervention using more modern methods? Digital interventions allow for the same kind of medication planning that we've been discussing, for prompts to patients and healthcare professionals, join up communication, and give real-time feedback to patients and their professionals, incorporating training with videos and so on available online. And they potentially allow the intervention intensity to be increased without increasing workload. We called this trial the Home BP trial, and we compared such a digital intervention with usual care. Again, the aim was to improve blood pressure control. And again, we saw improvements in systolic blood pressure, significant improvements in systolic blood pressure at 12 months. As you can see, this was slightly lower than some of the previous trials. There was no difference in side effects. There was high medication adherence throughout, but about 50% of the control group were doing ad hoc self-monitoring, which may be a reason for the slightly lower effect size. There were high levels of engagement, with 70% still monitoring after 9 months, and both dose increases and additional medications seemed to drive the benefit. These algorithms for the adjustment of antihypertensive medication have now been incorporated in the Omron Hypertension Plus system, and this allows the sorts of treatment plans that I've been describing to be set up. Here you can see erbisert on the top and timolol as potential examples, with blood pressure and pulse rate monitored over time, and the potential for patients to let them know if there are differences in side effects and so on. So how can we fit all of this together? Well, we've done an individual patient data meta-analysis taking 25 trials. Overall in the world literature now, there are well over 50 trials of self-monitoring, which generally show benefit. But here we had individual patient data from 25 of those, including trials from around Europe and from the US and from Australia, including some of Gianfranco's work. And we found that trials with self-monitoring, where really all you do is give someone a blood pressure monitor, have little effect, but trials where one does much more active things, as recommended in the US guidance, as you heard from Brian, things such as telemonitoring or self-management, or indeed things which involve quite significant intensity, such as pharmacists being involved on a monthly basis, show increasing benefit in terms of blood pressure lowering for increased intensity. So in conclusion, many patients have suboptimal blood pressure control. This is likely worse over the last 18 months with the pandemic. We have all the building blocks now in place to do successful self-monitoring on a really large scale. And in the UK, we have more than 200,000 monitors now distributed through the BP at Home scheme. Titration of antihypertensives by GPs and all their patients is cost effective and importantly is effective and importantly cost effective. And these can be implemented through digital solutions, allowing greater intensity without increasing workload. Very large numbers of people were involved in a lot of the trials that I've described. And we're mostly funded through the NIHR. Thank you very much.
Well, thank you, Richard. Another terrific talk covering all of the topics that we wanted to get covered during this session. We are very pressed for time. We started a little late, and I think we have to finish literally in a few minutes. So just quickly, are there any burning questions or any comments anybody would like to make? Maybe if you're in the room, Gianfranco, if there's anybody there who you can see who wants to make a particular comment. I can't hear you.
There is one question from Dr. Kotsis from Greece.
Okay.
Please, Vasilios.
Gianfranco, what is the time frame of this night blood pressure measures for home and night blood pressure monitoring? So it is going to be the first hours of the sleep, the morning, the after hours of the sleep. What do you think will be the most suitable time to measure blood pressure during nighttime?
Thank you for this question. It's a very important question, a very practical one. We have only a few studies available, and the idea is to limit the number of measurements to avoid interfering with sleep as much as we can. And based on the early studies, it seems that if you have at least 3 measurements scheduled in the middle of the night, 2 a.m., 4 a.m., and at least 4 hours after going to bed, seems to provide a more accurate information on the sleep characteristics. They did this by comparing these 3 measurements with the measurements scheduled every hour and to compare the averages. It seems to be quite corresponding, but is a preliminary evidence. We need much more studies also comparing this with HBPM and there is a couple of studies available already. The results are really promising, but I'm sure we need to investigate more because it might be used even better, in my opinion, but we have to identify how and why and in which patients. Maybe in some patients you may have different needs. So it's really a flexible tool that might require investigation.
Okay, thank you.
Thank you, Gianfranco. I've just had a message. We are pressed for time, so I'm probably going to have to wrap up the session with a few concluding remarks. I think it's been a really informative session. It's fascinating how complex something so seemingly simple is to communicate what we need to be doing in terms of home blood pressure measurement. And I think the addition of nocturnal measurements adds both a new opportunity, but also increasing complexity, as you've highlighted, Gianfranco, about how we will actually standardize those measurements so that we can get reproducible and meaningful data that we can translate into routine practice. I think from Richard's talk, what's fascinating is, again, the relative simplicity to do this, but also some of the overlaying complexity to get it absolutely right. And I was impressed by the fact that most of the home blood pressure measurement interventions that have been valuable have not just been about the measurement. They've been about some sort of supportive structure around the measurement that allows patients to better understand what the readings mean and also potentially use those values to modify their own treatment. And that won't work for everybody. It'll only work for certain groups of people. But what is clear to me is that moving towards home measurement is the way forward. This is going to be the future, I think, of blood pressure measurement for hypertension, both in terms of confirming diagnosis, but also monitoring the effectiveness of treatment titration and control. And the more technology and the better understanding of that technology that we can see developed is going to help us make sure that there is something that every patient can use wherever they are in the world in terms of monitoring their blood pressure control. I thank Omron for supporting this mini symposium, and also to outstanding speakers in Gianfranco Parati and Richard McManus. It's been a pleasure to share the podium with them today. Thank you very much for your attention.
Thank you.
Thank you.
Bye.